Welcome back. And the next section in our cardiovascular odyssey here is Dr. Greg Piazza, who's Associate Professor of Medicine at Harvard Medical School and directs the vascular medicine section in the cardiovascular division at Brigham and Women's Hospital. And he will walk us through an important topic for the boards, which is the management of peripheral arterial disease, including carotid disease and aortic disease. So, Greg, thanks so much for coming, and I'll hand it to you.
Excellent. Thanks, Akshay. And I'm very excited to be here and to participate this time virtually. As Akshay said, we're going to focus on peripheral artery disease. We're going to talk about pathophysiology and the symptom complexes of intermittent claudication and critical limb ischemia. Here are my disclosures. And so what I want to do over the next probably 35 minutes or so that I can leave some time for questions is help us to understand the natural history and pathophysiology of peripheral artery disease, focus in on the evaluation and management of intermittent claudication, and then highlight the assessment and treatment of patients with something called critical limb ischemia, which we'll go over. And in the midst of all this, we'll talk a bit about carotid and aortic disease. So when we think about the prevalence of peripheral artery disease, one of the most obvious things that we see is when we move from a population of patients that are younger to one that includes patients above 70 years or so and that have comorbidities that we know are associated with atherosclerosis, the prevalence of PAD really shoots up. So these are a number of really large data sets and different populations within those data sets. And as we go from the NHANES data set and looking at 40-year-olds and older to a mean age of 66 to 70-year-olds in the NHANES to a Rotterdam registry of greater than 55 years, finally to the Partners Registry, which had patients who were greater than 70 years or 50 to 69 years with diabetes and smoking, you can see just how high the prevalence of PAD goes. The presentation of PAD can actually be one of the most challenging parts of the whole disease. What makes it challenging is patients describe their symptoms differently. So 50% of patients with actually objectively proven peripheral artery disease won't have any symptoms at all. 15% will tell us about what we consider to be typical claudication. So reproducible limb discomfort in a defined muscle group every time they do the same amount of exertion. 15% is not a lot. 33% of patients will actually complain of what we call atypical limb symptoms. They'll report pain or some discomfort in their lower extremities, but it may not be every time they do the same level of activity, or it may have different symptoms in different locations. And 2% of the time we'll have patients who actually come in with ulcer or signs of tissue loss. Peripheral artery disease is really important to diagnose, less so for the impact on 5-year limb morbidity. If we look at that, we see that if you have a patient with claudication and peripheral artery disease, about 80% of those patients in 5 years will still have the same level of claudication. 1 to 2% of those patients will go on to develop critical limb ischemia. Maybe 10 to 20% of those patients will have worsening claudication symptoms. But most will continue to truck along and do relatively well from a limb standpoint. From a 5-year cardiovascular morbidity and mortality standpoint, that's where things are really important. There's a 20% chance of non-fatal MI and stroke and a 15 to 30% chance of cardiovascular death. So really identifying patients who have peripheral artery disease actually flags the patient as someone with a high risk of cardiovascular events. And that's why we want to really push all of our risk reduction techniques in these types of patients. We can localize or try to localize where the arterial occlusive disease is in patients with peripheral artery disease, depending on where their symptoms are located. So patients that have buttocks and hip claudication oftentimes will have either aortic or iliac disease. Those with thigh symptoms can have aortoiliac disease or sometimes disease in the common femoral artery. Patients that are complaining of calf claudication, that's usually a sign of superficial femoral artery disease. The lower 1/3 of the calf usually means the patient has popliteal or infrapopliteal disease. And then foot claudication, which we don't see that commonly, is usually a sign of infrapopliteal disease. So here's a case that we can use to illustrate claudication a bit. So this is a 67-year-old man with diabetes, prior smoking, hypertension, and high cholesterol, and presents with calf cramping when walking, especially noticing this when he climbs the hills on the golf course. But even now when he goes walking on level ground with his wife, he'll experience some sensation of calf cramping. The discomfort gets better with rest. His symptoms are worse on the left, but he does have some on the right. And we can see a picture of him there. So he comes in to see his provider. His provider does blood pressure in his arm and gets 172/82 in the right and 166/80 in the left. So he's got systemic arterial hypertension. Reasonable femoral pulses, 2+, no bruits. Popliteal pulses are diminished a bit bilaterally, 1+. And then the distal pulses are 1+ at the dorsalis pedis and posteriotibialis bilaterally. The ankle brachial index is measured in the office, and we'll go through that a little bit, but it comes out to be 1.1 on the right and 1.0 on the left. So normal at rest, and yet his symptoms really do sound like they're claudication. So what do we do in this case? So in a patient with exertional limb symptoms, but normal resting ankle brachial indices, what's the best initial diagnostic study? And so you have some choices here. We could go ahead and do an invasive angiogram. We could do a CT angiogram. We could do an MR angiogram. We could put the patient on a treadmill for a little while and see what happens to the ankle brachial indices, or we can do a vascular PET. So go ahead and vote. So it's, I think, a good sampling. We're over 100 of you that have voted, more than 100. So the correct answer here is actually exercise ABIs, okay? What we want to do is we want to provoke the symptoms and then see what happens to perfusion. And the only test here that includes provocation is exercise ABIs. All of the other tests might diagnose peripheral artery disease, but we won't really know if the peripheral artery disease is what's causing those symptoms. So exercise ABIs, which we'll review a bit more, is exactly what we should do here. And here we can see those answers. And so that's exactly what was done for this patient. So we can see at rest, the right ABI is 1.1, left is 1.0. With exercise, we're looking to provoke a drop in the ankle brachial index. And what do we see? A drop. So we go immediately post-exercise down to 0.7 on the right and 0.6 on the left, and then he recovers at 5 minutes post. So this is a patient with bilateral, left worse than right, peripheral artery disease that we brought on with exercise. So let's talk about the definition of intermittent claudication. This is a term, like I said, it doesn't describe every patient with peripheral artery disease. Many patients have atypical symptoms or no symptoms, but when we find this, we want to recognize it. It is reproducible discomfort in a defined muscle group provoked by exercise and relieved with rest consistently. Now, there are many other things that can cause limb symptoms with exertion. And so this table is actually very handy for kind of working through the different presentations. So intermittent claudication, the location of the pains, typically the buttocks, thigh, or calf. The quality of symptoms are crampy, achy, fatigue. The effect of exercise and rest, the onset after the degree of exercise should be the same. So if it's walking to the mailbox, it should be walking to the mailbox each time. There should be quick relief with rest, and it's reproducible. And if you find a patient with this, it's most likely to be peripheral artery disease. Spinal stenosis, we hear about patients who have leg symptoms radiating down from their back. It can follow the hip, buttocks, and thigh. It follows a dermatomal distribution, so typically down the lateral side of the thighs when it does go down the thighs. There may be some weakness, certainly some pain. The onset is with walking or standing and relieved with position change. So that's a little different than intermittent claudication. A patient with peripheral artery disease who has intermittent claudication doesn't need to change position. They can either slow down or they can stop and stand. But if you have a patient that has to change positions, either sit down on a park bench or lay down, that fits more with spinal stenosis. And oftentimes these patients will give you a history of back pain or back problems. Venous claudication is something you might see in someone who's had many DVTs or very proximal DVT. The discomfort's going to be the whole leg. It's described as a tightness that comes on with walking. But the trick here is it's slow relief with rest. Patients with venous claudication can take half an hour to decongest their limbs if they put them up on some pillows or in a recliner, whereas intermittent claudication should get better within 5 minutes or so just by slowing down. These patients will often have edema on exam, maybe some venous stasis, and oftentimes a history of DVT. So the ankle brachial index, this is something we can do in the office that will do many great things for us in the evaluation of these patients. First of all, we can answer the question whether there's peripheral artery disease. And second of all, we can identify a population at high risk for cardiovascular events. It's very sensitive, 95%, and very specific. And the way we do it is we, first of all, take blood pressures in both arms, and then we're going to take the highest brachial pressure and save that because that's what we're going to use for our brachial pressure. And then we use our Doppler to measure the dorsalis pedis pulse and the posterior tibial pulse. We inflate the cuff, make the signal go away, then decrease the cuff. And when the signal returns consistently, that's our sign of our ankle pressure. We do both the DP and the PT. That improves the sensitivity of the test, and we compare that ratio with typically 1 being normal, but recent data suggests that even 0.9 may be a reasonable cutoff. So we can see here the incidence of coronary heart disease events increases with a decrease in the ankle brachial index. So if we look at this, we see as our ankle brachial index goes from 1.1 to 1 to 0.9 to 0.9 to 0.7, and then less than 0.7, that 5-year risk of coronary heart disease events actually increases. Now, if you read more about ankle brachial indices, you'll see that there's somewhat of a debate about what are the numbers that you should use to calculate the ABI? And I make this really easy for us. It really just depends on what question you're asking. So if you want to ask the question, does the patient have perfusion-related symptoms? Then you're going to take the highest ankle pressure and divide it by the highest arm pressure. Why? Because perfusion to the limb and limb perfusion-related symptoms will only be as bad as your very best perfusion from an artery. So if you've got a higher number from the dorsalis pedis in that leg and a lower number from the posterior tibial artery, you're going to pick the highest of those two pressures to do the ankle brachial index. Why? Because like I said, perfusion is going to be only as bad as the best number you get. Now, if you want to assess for cardiovascular risk and you want to be very sensitive, then you're going to take the worst number that you get from that limb. So if it's the posterior tibial, that's the lowest pressure, you're going to use that one. And that's going to give you the best sensitivity for answering the question, yes, there's peripheral artery disease, and yes, they have atherosclerosis and an increased cardiovascular risk. And when we look at the correlation of ABI to the severity of PAD, I'll tell you, no matter what the ABI is, if it's abnormal, that correlates with a future risk of heart attack and stroke. So that's true for all of these abnormal ABI levels. But patients symptom-wise, if the ABI is 0.8 to 1 oftentimes they're asymptomatic. 0.4, or usually more like 0.5 to 0.8, they'll tell you about claudication or a typical limb discomfort. Less than 0.4, 0.5, then you might see a patient that comes in with either rest pain or tissue loss with an ulcer or dry gangrene. We call that critical limb ischemia. And that's a sign usually of blockages at multiple levels in the artery to the limb. This was a great article. When this came out, there were a couple of surprising things. This is a JAMA article from 2008, and it looked at total mortality in men and women by the ankle brachial index. And what we can see here is that when the ankle brachial index is actually greater than 1.4, we used to think that was normal. Actually, it's not normal because there's a higher mortality at that level. Normal is probably around 1.1 or so to 1.2. You can see here, even in the 1 to 1.1 range, mortality starts going up. And we used to give people, and some studies challenge this, but we used to give people a pass if their ankle brachial index was 0.9 to 1. But clearly, that's not totally normal, because the increase in mortality is seen there. And then as that ABI drops down to 0.6 or less, the mortality goes even higher. A word about ankle brachial indices. These are used to confirm the PAD diagnosis. It establishes PAD as the cause of the symptoms because you're provoking symptoms, and then you're showing that the ankle brachial index decreases. You use this to assess the functional severity of claudication, and you use it when a patient has a normal ABI at rest and you want to unmask that ABI and find peripheral artery disease. Another test that we do in the vascular lab is called segmental Doppler pressures, or pulse volume recordings. This is actually a very neat physiologic test that gives you anatomical localization of the peripheral artery disease, and it also tells you just about how bad things are. So we can see our patient here. He's got a cuff around the upper thigh, lower thigh, below the knee, and ankle. When we do this in our labs, we also have a cuff across the forefoot. And here's an example of what we do to examine this. First of all, we take 2 brachial pressures. We look to make sure there's not a difference of more than 20 millimeters of mercury in the brachial pressures. If there are, then there's some subclavian disease, and we want to know that. We then take the highest of these numbers and go down one limb at a time. So here's the highest is 112. We go down this limb, 112, the pressure goes up to 140. That's good. We expect something called femoral augmentation, partly due to gravity, partly due to the elastance of the femoral arteries, but we expect that pressure to go up. If it doesn't go up, that is a sign of some possible peripheral artery disease. So we're happy to see this go from 112 to 143. And now we go from 143 to 106. So that's a problem. That's a greater than 20 millimeter of mercury drop. And so that corresponds with some femoral artery disease. Then we go from 106 to 92. That is not quite 20 millimeters of mercury, so we give that a pass. And then we go from 92 to 88 and 94. So we know in this limb, there's some femoral artery disease. Now we go down the other side, 112 to 110. That's not good. We're supposed to have this go up or at least stay the same, but we go to 100. So now we know that there's probably some iliac disease in here. We don't think there's our aortic disease because the other side didn't have a drop. So this is iliac disease. We go from 100 to 110. That's okay. We can go up a little bit. 110 to 102. That's okay. And 102 to 85 to 103, that seems to be all right. So what we've got here is a patient with femoral disease on this side and likely iliac or very high up in the common femoral artery disease. So bilateral disease in this patient. If we look at our guidelines for peripheral artery disease, we always start with a good history and physical. We get that ankle brachial index. If it's normal, then we're going to, and we do think the symptoms are exertional, then we're going to do exercise ankle brachial indices. Abnormal ABIs, that's great. If they're abnormal at rest, we know there's peripheral artery disease, and then we can investigate that further. Something can happen sometimes in our patients with diabetes or a chronic kidney disease where their arteries are calcified and stiff, and so we inflate the pressure cuff, and we keep inflating, and we can't get the signal on the Doppler to go away. Those are calcified vessels. They're called non-compressible arteries. And that makes it so that we can't use the ankle brachial index to diagnose peripheral artery disease. The good news is toe arteries do not calcify typically. So we can do something called a toe brachial index, where we put a little blood pressure cuff around the great toe, and the normal there is greater than 0.7. We can use that to diagnose peripheral artery disease. So we've got a lot of neat tools at our disposal in the vascular lab. When we diagnose peripheral artery disease, we have a couple of goals. We do want to make sure that our limb outcomes are as good as they can be. We want to improve walking distance. We want to make quality of life better. And we want to reduce the risk of critical limb ischemia or amputation. Those aren't common, but they do happen, and we want to prevent that because that's a big hit to patients' functional status. Cardiovascular outcomes, of course, we want to reduce that 5-year risk of stroke and MI, and we want to reduce cardiovascular mortality. So we're going to focus all of our disease prevention efforts on that. Statins, controlling blood pressure, getting patients to stop smoking, all of the stuff that we know is important. All right, so what do we got here? We have a question. A 64-year-old woman, COPD, cigarette smoking, hypertension, right leg claudication, has an ankle brachial index of 0.6. What's the most important thing we can do for this patient? We could give her cilostazol, try to make those symptoms better. We can give her rivaroxaban and aspirin, like was studied in the COMPASS trial, see if we can make some headway with her risk reduction. We could have her quit smoking, or we could do lower extremity bypass surgery. What is the most important thing we're going to do here? Let's see if we can get 100 people to vote on this here. Well, that is fantastic. Yes, smoking cessation is the most important thing that we can do for this patient. What do we want to do? We want to improve symptoms, quality of life, reduce that 5-year risk of cardiovascular events. Is cilostazol going to do that? No. Will rivaroxaban and aspirin help? Yeah, we'll reduce the risk of cardiovascular events. The COMPASS trial showed that, but it's not going to change the claudication necessarily. Lower extremity bypass will help the claudication for sure, but it's not going to change the cardiovascular risk. What'll do both? Smoking cessation. Smoking cessation will prevent the progression of disease, it can improve symptoms, and it's going to dramatically lower the risk of stroke and MI. So you all did wonderfully with that. On to our next here. All right, and so when we look at the recommendations for managing claudication, yeah, class 1 indication, everybody's got to quit smoking if they're a smoker. We want to leverage all of the tools that we have to do that, and we also want to make sure we're limiting environmental smoke exposure. What else can we do for our patients? Well, antiplatelet therapy gets a class 1 indication to reduce MI and stroke and cardiovascular death. Certainly, if patients are asymptomatic, it's a little bit of a weaker recommendation, but we still push the antiplatelet therapy. Statins are key. And then treating hypertension, also very important. What you treat them with really, depends on what they're going to tolerate and their other comorbidities. One trial or one sub-analysis of the HOPE trial suggested that ACE inhibitors may have some effect on claudication. And that would be ramipril specifically. What else can we do? Well, structured exercise therapy has had a renaissance as of late and is highly effective for improving functional status and quality of life. The question is, where do we do structured exercise? Well, some of our hospitals do have structured exercise programs for claudication. We have a program, but they're few and far between. option would be some sort of a home exercise program. If it's not structured, it's probably not as effective, but that is something that we can push for our patients. And I'll say anecdotally, I'll have my patients start on walking programs and I'll write out a prescription. And if they're consistent with it, they will see benefit for their symptoms. 2 meta-analyses looking at exercise therapy for claudication, and what you see with this is an improvement in walking distance and pain-free walking. Exercise is really fantastic for these patients. And for patients that don't respond to typical medical therapy and exercise, we can think about endovascular procedures or surgery. Typically, we're looking for patients that have pretty severe symptoms that are lifestyle limiting. And we can see here indications for intervention: lifestyle limiting claudication despite optimal medical therapy, or rest pain, non-healing ulcer, or gangrene. Those are critical limb ischemia, and we do want to revascularize before there's more loss to tissue. CLEVER was one of these very important studies looking at supervised exercise versus stenting. It's a busy table, but I can tell you the upshot of this study was in patients with claudication due to aortoiliac disease, a supervised exercise program functioned very effectively, really challenging the effect of revascularization. If you can get a patient to do supervised exercise and optimal medical therapy, they're going to see some benefits, and you can oftentimes avoid the need for stenting. All right, in our patient with claudication walking the golf course and abnormal exercise ABIs, which additional screening tests should be performed? A stress echo, because we talked about PAD being related to CAD. Stress nuclear perfusion scan, again for the same reason. An abdominal ultrasound, a coronary angiogram. We're just going to dive right in and see whether they have coronary artery disease, or a carotid ultrasound. Go ahead and vote. It's a little more of a nuanced question, so I can see some hesitation, and it's understandable. But it does seem like you have all focused on abdominal ultrasound as a good choice, and that is actually the correct answer. So in this patient who has a history of smoking and peripheral artery disease, an older male, we're going to do an abdominal ultrasound. What for? Well, we're going to want to look for aortic aneurysm. So if you'll remember, the recommendation from the U.S. Preventive Services Task Force is that patients 65 or older with a history of ever smoking, especially if they're men, should undergo an abdominal ultrasound for screening. And we can see that here. Ever smoked, it doesn't really matter how much or how little, they get a one-time ultrasound to look for abdominal aortic aneurysm. Here's an example of a patient with an enlarged aorta. All right, case 2. We've got to hustle on this case, but luckily this one's even a bit more straightforward. 72-year-old woman, poorly controlled diabetes, chronic kidney disease, hypertension, and coronary artery disease, coming in with painful right foot and non-healing ulcers. Her leg feels better when it's dangling off the bed, and she describes multiple ulcers on both feet. They've been there for months. And we do our exam, and she's got these numerous ulcers, varying depth with some erythema in places and a little bit of scant discharge. This is one of the drier ones. She has 1+ femoral pulses bilaterally and non-palpable popliteal pulses. You can barely Doppler her distal pulses at the PT, and you can't really get them at the DP bilaterally. Very depressed ankle brachial indices, 0.3 on the left, 0.2 on the right, and guess what? Also has bilateral carotid bruits. Here's an example of one of those. Ulcers. This patient has critical limb ischemia. It's arterial ulceration that is on the spectrum of rest pain and gangrene. These patients usually have 2 or more levels of arterial tree being stenosed. And if we leave this alone, there's an increased risk of tissue loss or amputation. And so we'll want to revascularize these patients. Here we can see the fate of patients with critical limb ischemia. Really, in addition to the cardiovascular complications that we have, cardiovascular death, we're worried about amputation. Amputation really limits patients' ability to rehab. Their functional capacity declines significantly. Determining the cause of an ulceration is one of the challenges, but I've got another table for us that helps us navigate this, and this is also really helpful. Arterial ulcerations, typically seen shins, toes, sites of injury, could be even minor trauma from the rubbing of a shoe, a tight shoe, a strap. Painful, very painful ulcers. Skin's going to look shiny, pale. There may be hair loss. You can see livido reticularis. The ulcer's going to be dry. It's going to be pale because blood flow is not good, and you may see a black eschar on the side. These patients oftentimes are going to have a history of things being smokers or some other clue. The edges of the arterial ulceration will be smooth. Venous ulcers, perimalleolar typically. Really not that painful unless the skin's, really raw, then it might be uncomfortable. Nowhere near as painful as an arterial ulcer. There'll be stasis pigmentation and edema. Perfusion's actually fine. So you're going to see they'll be wet, weepy, there'll be plenty of good granulation tissue. If you look at the edges, they're clean. A neurotrophic ulcer, these are ones that you might see in someone with bad diabetic neuropathy, plantar surface, pressure points, no pain. They can't feel much because of the neuropathy, and that's how they're able to keep traumatizing the area to get these types of ulcers. So they don't really feel that much pain, calloused from repetitive trauma. Perfusion, again, is great, so they're going to have healthy, pale, healthy-looking granulation tissue, but it may be pale due to the calloused nature of the ulceration. We can do segmental Doppler pressure with pulse volume recordings if we want to know what level of disease is there in an ulcer. We should see multiple level disease. You can see here that we're dealing with ABIs 0.39 in the thigh all the way down to 0.19, 0.27 on this side, 0.4, 0.5. That's the neighborhood that we want to see for someone who has ulcers due to arterial insufficiency. If we're thinking about revascularization, this type of a map won't be enough, and we're going to want to do an MRA, a CTA, or a conventional angiogram so that we can give our interventional colleagues or our surgeons a good planning map for revascularization. And here we can see our guidelines. How do we handle this? Well, we're going to start, we've got an ulceration or some other suspicion of critical limb ischemia. Could be rest pain, could be gangrene. We're going to do that ankle brachial index. We want to see it low. We want to see it really low. If it's not low, then we have to question whether this is arterial in nature. Could be venous, could be neurotrophic. But we want to tease that out with the ankle brachial index. Looking at our guidelines, we're going to want to reperfuse these patients. If we can get flow with an endovascular procedure, that means we've done our MRA, we've done our CTA, and the anatomy is favorable for stenting. It's a great idea. We can go ahead and do that. Stenting works best for the iliacs. So if we see inflow disease, which usually is meant to imply the common or external iliac, that's a good place for a stent. Sometimes we have to do staged procedures. If we're going to do a staged procedure, we're going to improve that inflow first, and then we'll worry about whether we have to try to stent or do surgery on more distal disease. For surgery, we want to try to get complete revascularization. So if we're going to do a bypass, we want to go past as many of these blockages as we can, and we want to use vein graft if we can. We really want to try to avoid using graft material because the patency rates are not that good. All right, and here we can see 5-year patency. It's best if we do an aortobiFEM. As we start to go distally, the patency rates aren't as great. The most proximal that we can land our graft, the better. Okay, which of the following is most likely to reduce a PAD patient's risk of cardiovascular events? Cilostazol, rivaroxaban plus low-dose aspirin, dual antiplatelet therapy, Vorapaxar, which is another type of antiplatelet therapy, or patoxyphylline, which is Trentol. Go ahead and vote. And we're going to try to wrap this up because we want to get going here. We are close to the end. So go ahead and vote and see if we can get a little bit more of a consensus here. I see 2 and 3 really battling, really going at it here. All right, let's go on to the next slide. So it's actually rivaroxaban plus low-dose aspirin. Cilostazol may help a little bit with claudication symptoms. It's certainly not going to reduce cardiovascular events. COMPASS trial, which we're going to talk about, showed a very nice reduction with a combination of rivaroxaban and low-dose aspirin. Dual antiplatelet therapy has been pretty disappointing. Vorapaxar has shown some promise, but it's really underused and very high risk of bleeding there, and certainly not as impressive as rivaroxaban and low-dose aspirin. Trentol really doesn't do much of anything in these patients. Euclid was a very nice study looking at intense antiplatelet therapy, looking at ticagrelor versus clopidogrel in patients taking aspirin. Really not an impressive change, no significant difference there in their primary endpoint of cardiovascular events. COMPASS was a very interesting study focused on patients with stable cardiovascular disease and looking at antiplatelet disease alone, a higher dose of antithrombotic therapy, or this combination of low dose antithrombotic therapy with antiplatelet therapy. And what they found was there was something special about the combination of low-dose rivaroxaban and aspirin that reduce a composite of cardiovascular death, stroke, or MI. And this COMPASS regimen is something that's become very important for our patients with peripheral artery disease. It may also show a very nice benefit for reducing major adverse limb events like amputations. So this is becoming an option. It's somewhat underused. We probably should be using it more. Along the similar lines, recently presented was the Voyager PAD published in the New England Journal. These are in patients who had PAD revascularization, but again, looking at that same special regimen of low-dose rivaroxaban and aspirin. And what they were able to show is that regimen actually, again, reduced MI, stroke, cardiovascular death, and major adverse limb events. And my friend Mark Banaka worked on that study. So very important in patients who've been revascularized to consider this antithrombotic and antiplatelet regimen. We can't forget about our carotid bruits, right? Analysis of 28 prospective cohort articles and many patients has found that carotid bruits associated with TIA, stroke, and fatal stroke. And our patient has one, so we're going to want to do a carotid ultrasound. If we can do the carotid ultrasound and we diagnose carotid artery stenosis, then we've got to make a decision about whether we're going to or not. And revascularization really requires us to be multidisciplinary in our decision making. Typically, we think carotid endarterectomy over carotid artery stenting when possible. Beware of polyvascular disease. This is actually my second to last slide, I believe. Patients that have PAD, like this patient does, and carotid artery disease have a higher risk of developing venous thrombosis. And if she has coronary disease, which we probably already have a high suspicion of, very high risk of venous thromboembolism. So we're going to want to worry about that in this patient. So take-home points. Diagnosis of PAD identifies patients at risk for limb-associated morbidity and cardiovascular events. Our approach to PAD and claudication focuses on risk factor reduction, medical optimization, supervised exercise if we could get it, and revascularization for the patients that still have symptoms. Critical limb ischemia, we want to emphasize optimal medical therapy right away, but also revascularization whenever and however possible. And with that, I want to thank you all for great attention, and here are some extra references.
Thanks so much, Greg. This was fantastic, and we've given you an impossible task of covering a large amount of material. The one thing, we don't have time for a lot of questions now, but just one general quick question, and then we'll push the others if you're able to come back for our Q&A at the end. If not, then maybe we'll hand them to you by email. But just generally about screening, if you see PAD in somebody, should you be looking at all their other vascular beds routinely, carotid disease and other things, or is it all symptom-driven?
Yeah, it's mostly symptom driven, because when you diagnose peripheral artery disease with the ankle brachial index, you've already reclassified this patient to a very high cardiovascular risk. So you're going to maximize all of your risk reduction techniques on this patient. If they do, you're going to take a careful history, of course, for angina, and you're going to listen to their carotids. But in the absence of finding symptoms or a clinical syndrome, you're just going to push medical therapy as hard as possible.
Wonderful. Well, we may come back to you with some additional questions, but just in the interest of moving the program along, I think we'll close this session. Thanks so much for coming.
Excellent. Thanks, Akshay.